Good afternoon, everybody. I'm Dr. Rachana. Completed my DRNB Neonatology from Fernandez Hospital. Now working as consultant neonatologist in KIMS Cuddles, Kurnool. Today I will talk on apnea of prematurity. So as a comprehensive overview, I'll discuss on the definition, pathophysiology, classification, those are the types of apnea, secondary causes, the factors contributing to apnea, the monitoring part, that is the techniques for observing apnea, and treatment and evidence. So how is apnea defined in literature? According to American Academy of Pediatrics, they define apnea as a cessation of breathing for 20 seconds or longer or shorter pauses with bradycardia, cyanosis or pallor. European Journal of Pediatrics also defined similar as the pauses of breath for more than or equal to 15 to 20 seconds or desaturation less than 80% for more than 4 seconds and bradycardia in less than 37 weeks of PMA. Canadian Pediatric Society defined a cessation of breathing for more than 20 seconds or 10 to 20 seconds accompanied by bradycardia or desaturations, that is saturation less than 80% in less than 37 weeks of postmenstrual age. So overall it defines as there is a cessation of airflow that is around 20 seconds. If it is lesser than 20 seconds, it has to be associated with bradycardia and desaturations. The definition for bradycardia and desaturation, like to consider as heart rate less than 100 or less than 80 or saturation less than 85% or 80, that there is no clear consensus on that. But it's been defined as bradycardia associated with bradycardia and desaturations. Usually the incidence of apnea is more in the preterms. So it is inversely proportional to the gestational age. As the gestational age increases, the incidence of apnea also comes down. Like in late preterms, that is 34 to 35 weeks, so the incidence is around 7%. In 32 to 33 weeks, around 15%. And 30 to 31 weeks, 54%. Almost 100% in less than 29 weeks and less than 1 kg. And this apnea of prematurity may last up to 44 weeks of postmenstrual age. According to the KIMS study, they examined the occurrence of apnea and bradycardia events in 1,000 preterms and healthy term infants who were monitored at home. The extreme events were observed most frequently in the preterms and decreases dramatically at 43 weeks of postmenstrual age. So as I said, the incidence of apnea increases in the preterm. So what are the causes of apnea in the term infants? It can be due to birth asphyxia, intracranial hemorrhage, seizures, or drug effects which depresses the central nervous system, or structural abnormalities. Structural abnormalities in central nervous system, like one of the most common is the Joubert syndrome, where the baby can have the recurrent episodes of apnea. So one of the structural abnormality in CNS can also cause apnea in term infants. Usually we get confused with the apnea and the periodic breathing. So the differentiation here is the periodic breathing is regular, recurrent cycles of breathing of 10 to 15 seconds duration that are interrupted by pauses of at least 3 seconds in duration. And they are benign respiratory pattern for which no treatment is required. And this is a self-limited, and once the pauses, the respiratory pauses stops, the ventilation continues. But apnea of prematurity has a prolonged apnea and they fail to reinitiate ventilation entirely or they do it inefficiently. So that's why they will be in the bradycardic state or the desaturation state. So they require treatment, and these respiratory pauses during the apneas are associated with the shallow movements. So treatment is required in apnea of prematurity. The factors implicated in the pathogenesis of apnea of prematurity can be central mechanism or peripheral reflex pathways or others. In centrally, it is due to decreased central chemosensitivity, hypoxic ventilatory depression, or upregulated inhibitory neurotransmitters like GABA and adenosine. In peripheral reflex pathway, the carotid body activity can be increased or decreased, laryngeal chemoreflex, or excessive bradycardic response to hypoxia. Others can be like genetic predisposition, sepsis, and hyperbilirubinemia. The apnea of prematurity is defined as a developmental disorder that reflects physiologic rather than the pathologic immaturity of respiratory control. It has two functions, that is anatomically and functionally. Anatomically, if we see the development immaturity of the central respiratory drive causes occurrence of apnea may correlate with the brainstem neural function. In preterms, there is decreased number of synaptic connections and dendritic arborations, and there is paucity of myelin. This predisposes to apnea in preterms. Functionally also, the auditory evoked responses are impaired in infants with apnea when compared to the masked preterm control subjects, indicating a delay in conduction time. And this delay improves after the treatment of aminophil. So this indicates that there is a functional problem also, apart from anatomical problem. The chemoreceptor response, like central chemosensitivity, the major chemical drive of central respiratory output is elevated carbon dioxide. The preterm infants have a blunted ventilator response to the elevated carbon dioxide. So this response is very lower in the preterm infants with apnea compared to their masked preterm infants without apnea. Usually, PCO2 retention, that is increased PCO2, hypercapnia or hypoxia, and acidosis. These three things plays a major role in activating the chemoreceptors at the central and peripheral. So the ventilator response to carbon dioxide is the net result of activation of both peripheral and central chemoreceptors. And these are impaired in the preterm infants compared to the normal newborns. This is called as impaired hypercapnic ventilator response. Usually what happens when there is a increase in carbon dioxide, these central and chemoreceptors get activated and they initiate the respiration. And increases, hyperventilation happens. But in preterm, this is impaired. This mechanism can be impaired because of changes in the mechanical properties of the lung, or immaturity of the peripheral or central chemoreceptors, or changes in the central integration of chemoreceptor or other neuronal signals. So here in this graph, we can see x-axis there is the partial pressure of carbon dioxide, and in y-axis there is the ventilator response. So in between you can see the FiO2, that is inspired oxygen, ranging from 15 to 100%. So here in this graph we can see when the baby is receiving FiO2 of around 21% for that appropriate carbon dioxide, you can see the response when it is increased to 40% and 100%, how the ventilator response also has increased. So if there is an increase in FiO2, it increases the ventilator response also. In adults, the lower the concentration of inspired oxygen, the greater is the response to carbon dioxide. But in the preterm infants, the lower the concentration of inspired oxygen, the more depressed or flat is the response to CO2. Here you can see from 15% to 100% how the it is varied for the response for the carbon dioxide. So it is better in when the FiO2 increases compared to the lower FiO2. Peripheral chemosensitivity usually is it is controlled by the carotid bodies, and there is a biphasic response to the hypoxia. Biphasic response is first there will be hyperventilation, and then there will be apnea to the hypoxia. This persists up to 38 weeks and may contribute to the persistence of apnea in some of the preterm infants. And here in preterms, there will be both enhanced and reduced peripheral chemoreceptor functions. There can be decreased peripheral sensitivity. In utero, the carotid chemoreceptor O2 sensitivity is adapted to a normal low PO2. But in response to the fourfold increase in PO2 after the birth, the chemoreceptors are still silenced. There is increased peripheral chemosensitivity in response to the repeated hypoxia that as we see in BPD, which destabilizes the breathing patterns. This is because of the baseline PCO2 and the apneic PCO2 thresholds are very narrow in the preterm infants. Respiratory muscles also contributes to the pathogenesis of apnea. There is ineffective ventilation due to impaired coordination of the inspiratory muscles, that is diaphragm and intercostal muscles, and the muscles of the upper airway, larynx and the pharynx. So whenever there is an upper airway obstruction, the vulnerability increases in the preterms because of the poor muscle tone, especially during the REM sleep. And a passive neck flexion can obstruct the airway. Even nasal obstruction also, a local nasal obstruction also can cause apnea. So the activation of intercostal muscles contribute to the chest wall stability and maintenance of the FRC. The intercostal muscles are tonically inhibited during the REM sleep, leading to chest wall collapse and decreased FRC. Premature infants at baseline have less rigid airway, more prone to collapse, leading to obstructive airway, obstructive apnea. That is why we see a lot of preterm babies going into apnea during the REM sleep. And reflexes also contributes in the apnea. There will be activation of inhibitory upper airway reflexes like laryngeal chemoreflex, which precipitate apnea due to stimulation of posterior pharynx, lung inflation, fluid in the larynx, or chest wall distortion. Genetic predisposition like mutation in the FOX2B gene, which is seen in congenital central hypoventilation, or there can be even a polymorphism in the A2A adenosine receptor predisposing to apnea. Infection, that is local or systemic inflammation, increases the expression of inflammatory mediators in central and peripheral nervous system. These mediators can modify the structure and function of chemoreceptor. The activation of the IL-1 receptor induces the synthesis of prostaglandin E2, which when released into the respiratory related regions of the brainstem results in respiratory depression. So many of the time when the baby is having sepsis, we see that one of the presenting complaint can be just apnea. This is because of the cytokines and the inflammatory mediators suppressing the respiratory related regions. Gastroesophageal reflex, there is no temporal association with the apnea of prematurity. Despite there is a frequent coexistence of apnea and GR in the preterm infants. But GR does not prolong or worsen the concurrent apnea. Few of the upregulated inhibitory neurotransmitters like GABA and adenosine also plays a role in the pathogenesis of apnea. Even the hyperbilirubinemia, like the unconjugated bilirubin, crosses the blood-brain barrier and causes brainstem dysfunction. This results in decreased respiratory drive in response to either hypercapnia or hypoxia. So because of the immaturity, there will be hypoxic depression. There can be diminished hypercapnic responses and enhanced inhibitory reflexes leading to apnea. According to classification of apnea, there are central, obstructive, and mixed. Central, it is characterized by the lack of respiratory effort with no evidence of obstruction. The incidence is around 40%. In this central apnea, there is no diaphragmatic activity, no chest wall or abdominal movements. Compared to the obstructive, it is characterized by the absent respiratory flow, measured usually at nasal level. And this is one of the rare incidence is around 10%. Here there is a respiratory efforts present and manifested by increased chest wall or abdominal movements. Mixed apneas are characterized by central loss of respiratory drive followed by the airway obstruction. So it is the combination of the central as well as the obstructive apnea, which is one of the most common cause. Around 50% is the incidence, which has components of both central and obstructive apnea. Here in this diagram, we can see the central apnea where there is no flow, no chest movements and no abdominal movements. Compared to the obstructive apnea where there is respiration is present, there is movements of chest and abdominal movements. When we see the mixed apnea, starting there is a central apnea that is no flow, followed by there is a flow and the body movements, followed by the obstructive apnea. So mixed apnea has both of the components. Here again, we can see that central in the mixed apnea, the central apnea followed by the central apnea is followed by the obstructive apnea. The bradycardia and desaturation sets in when there is a obstructed breath. Usually, the diagnosis of apnea of prematurity is a diagnosis of exclusion. First, the secondary causes has to be ruled out, and then you can label as a apnea of prematurity. And this usually it happens within the first 7 days of the life. Most of the times, more than 1 week of life, it will be the secondary causes. In the secondary causes, the most common will be the infections like sepsis, pneumonia, meningitis, or NEC, which presents like a lethargy, decreased feeding, fast breathing, retractions, bradycardia or tachycardia, and with or without shock. Investigations like septic workup and chest X-ray can be done. Even a temperature instability like hypothermia and hyperthermia, presenting as cold peripheries, can also have apneas, where temperature monitoring can be done. Metabolic conditions like acidosis, hypoglycemia, hypocalcemia, hyponatremia, and hypernatremia, presence like jitteriness, poor feeding, and seizures can also have presence with apnea. So, whenever the baby is having apnea, first check whether it is a central or a obstructive. If it is a obstructive because of pooling of secretions or the neck position or nasal obstruction, that can be reviewed. Even if it is a central, then you can go for the temperature check, then GRBS check. Then later on followed by the certain investigations depending on the clinical features. If baby is having any neurological system involvement like intracranial infection, IVH, seizures, or baby is having perinatal asphyxia, you can go for the cranial ultrasonography, which will detect if there is any bleed, anything in the brain parenchyma. They will present as a sudden onset of pallor, shock, deranged sensorium along with the apnea. Even a cardiovascular system involvement like congenital heart disease, PDA, or in failure, they also can present with the apnea along with the tachycardia, bounding pulses, murmur, or increased requirement of respiratory support. Hematological conditions like anemia and polycythemia can also present with apnea along with pallor or plethoric. Even through the hemoglobin investigation, we can rule out if any such conditions is associated. Pulmonary conditions like RDS, pneumonia, obstructive airway lesions, pneumothorax, neck flexion can also present with apnea along with respiratory distress or reduced air entry. Even gastroesophageal reflex or abdominal distension NAC as discussed can also present with apnea. So whenever the baby is presenting with the apnea, first rule out whether it is the central cause or the obstructive cause. If it is the obstructive cause, it can be reversed. If it is a central cause, you have to associate the other any clinical features as discussed now, and can get the investigations and treat the cause, secondary causes. Monitoring of apnea can be done directly or indirectly, like directly by CO2 measurement or temperature variation. Indirect measures like pneumatic respiration, transthoracic impedance plethysmography, or whole body plethysmography. The cardiorespiratory monitoring is mandatory in children younger than 35 weeks of gestation in view of higher incidence of apnea. So all those babies less than 35 weeks has to be monitored for heart rate saturations, and clinically also for any cessation of airflow. Combined use of respiratory impedance, heart rate, and pulse oximetry monitors can also be used. Non-invasive measurements can be done by help of pulse oximetry, mattress motion sensors, nasal thermistors, pneumatic abdominal sensors, and carbon dioxide sensors. Commercially, there are few available monitors like Bempo Apnea Boot, Belly Button, Moon Baby, Snooza Hero Baby Movement Monitor, Miku Smart Baby Monitor, Owlet Smart Green Sock Baby Monitor, or Baby Sense. All these, the impedance apnea monitors does not detect the obstructive apnea. These are only for the central cause. So this is the bamboo apnea boot. Here you can see the boot which is put to the foot of the neonate, which detects the bradycardia and desaturation and gives a alarm and automatically also gives a tactile stimulation. So it's one way for detection as well as it treatment gives the stimulation to resolve that central apnea before the prolonged hypoxic injury sets in. And this is the baby sense, which is actually a non-contact, which is attached to the bed in any no movement, and then this gives an alarm. This is the sock, which is similar to the apneic board, Ovulet Smart Green Sock, which monitors the baby's movements, and if there is no movement, it gives the alarm and vibration also. Similarly, this is the movement monitor, Snooza Hero, and this is the bamboo belly button. This button can be fixed to the diaper, but it has to be in touch with the baby's body surface area. And if any point there is apnea, up to 20 seconds, you can set how much over the time you are setting, 20 seconds. Then even after the 20 seconds, if there is no body movements, it gives the vibration, and this can be connected through the Bluetooth to the phone, and even gives the alarm to the phone also. Even after vibration, if the baby doesn't breathe, again it vibrates and gives the alarm to the phone. It's quite helpful in NICU as well as in the home monitoring. Now, in the treatment and interventions for the apnea, certain preventive measures like positioning. Consider prone positioning for the preterm infants. It helps in improving the thoracoabdominal synchrony. And because of the prone position, the tongue fallback won't be there, and there will be that airway patency will be maintained, and the obstructive apnea incidence will come down. Maintain a thermo-neutral environment, and maintain the saturation between the target saturation 88 to 94%. Pharmacological interventions like methyl xanthine therapy, most commonly is the caffeine citrate. The second is the doxapram. Ventilator strategies like CPAP, high flow nasal cannula, or synchronized nasal intermittent positive pressure ventilation. Others can be like non-invasive stimulation like olfactory, mechanosensory, or any sound stimulation, music therapy, increased inspiratory carbon dioxide concentration, oxygen administration, even RBC, PRBC transfusion, if it is associated with GR, the management of GR also. First, whenever there is baby is having a apnea, initial stabilization to be done, that is by tactile stimulation. Even after tactile stimulation, if the baby doesn't review the breathing, go for bag and mask ventilation. Even on the bag and mask ventilation, baby has no, you have to go for the respiratory support, depending on the baby's condition. If the respiratory efforts are less, go for the mechanical ventilation. Pharmacological interventions, some methyl xanthines like theophylline and caffeine citrate. Now, most commonly, we use the caffeine citrate. Dose being 20 mg per kg, then followed by loading dose, then followed by maintenance dose of 10 mg, 5 to 10 mg per kg per day, given only once a day. And heart rate, apnea, and serum caffeine levels can be monitored. Theophylline, loading dose of 6 mg per kg and followed by 2 mg per kg per day as a maintenance therapy in a divided TID doses. Where again the vitals has to be monitored. Indications are when there is apneic episodes are frequent, or if the baby requires PPV for apnea that is unresponsive to tactile stimulation. Whenever methyl xanthines are started, it helps in decreasing the inflammation, increases the white matter stability. As a respiratory system, it increases the respiratory neural output, decreases the ventilatory support, decreases the hypoxic episodes, and overall improves the neurorespiratory outcome. Caffeine is a trimethyl xanthine. The mechanism, there are three mechanisms of action. The most common is the adenosine antagonism. Adenosine A1 receptor and A2A receptors caffeine acts on these two receptors, which gives a therapeutic level. And there is a blockage of adenosine receptors leads to important secondary effects on other neurotransmitters like adrenaline, dopamine, serotonin, acetylcholine, glutamine, and GABA. The second mechanism is the phosphodiesterase inhibition, which is a weak inhibitor. It prevents the breakdown of CMP, and increased CMP lead to CNS stimulation. At therapeutic doses, unlikely to mediate this effect. Third is the intracellular calcium mobilization. It also inhibits the voltage sensitive calcium channels, leading to inhibition of neurotransmission. These effects occur at higher levels, maybe at the toxic levels. So whenever the baby is receiving the caffeine, so these are the respiratory enhancement you can see. There will be improvement in the minute ventilation. There will be increased respiratory rate and better gas exchange. Bronchodilation is response seen through the caffeine. This is because of increased CAMP and CGMP levels. There is improved carbon dioxide sensitivity, which we see which is impaired in the preterm infants. So there is improved respiratory pattern and reduced hypoxic depression. There is increased skeletal muscle tone, uh, improvement in the peripheral chemoreceptor activity, which leads to apnea termination. There is increased diaphragmatic contractility, increasing the lung capacity through that. And there is a medulla stimulation, which terminates the apnea and continues the normal breathing. When the caffeine is administered, there is increases the metabolic rate, which increases the oxygen consumption, and there is enhanced catecholamine secretion, which stimulates the myocardium and increases the heart rate, cardiac output, stroke volume, and MAP. This also has an effect on renal, that is, there is diuretic effect by increasing the GFR, and there is increased calcium excretion. It also alters the glucose hemostasis, and there is a immunomodulatory effect, that is therapeutic level. There is anti-inflammatory action, that is decrease in IL-6 and TNF alpha and increase in IL-10. There is pro-inflammatory action if the caffeine goes above the therapeutic levels. It also delays the gastric emptying, so it decreases the tone of lower esophageal sphincter and increases the gastrin secretion. Caffeine rapidly and completely absorbed orally within almost no first pass metabolism. The bioavailability of the oral dose is not disturbed by concomitant feeds. The peak of plasma concentration by both oral and IV route is almost the same. The therapeutic levels has to be maintained between 5 to 20 microgram per ml. And this reaches within the 30-minute to 2 hours. It has a longer half-life around 100 hours. This is because of the immature hepatic metabolism and renal excretion, because around 85% is unchanged and passes through the urine. Rapidly distributed into the brain, and in preterm infants, the levels of caffeine in the CSF approximates the plasma levels. The side effects of caffeine are tachycardia, feed intolerance, and increased metabolic rate. So comparing the caffeine and the theophylline, according to the mechanism of action, caffeine is more CNS stimulation and lesser of cardiac and diuretic effect, whereas theophylline, it has more of cardiac stimulation compared to the CNS stimulation. In pharmacokinetics, caffeine, we give loading dose of 20 mg per kg and maintenance of 5 mg per kg. Half-life, as I said, it is more, a mean around 1 or 3 hours. And therapeutic level is maintained in between 5 to 25 mg per liter. And toxic levels happens when the caffeine levels increases more than 40 milligram per liter, where compared to the theophylline, dose is lesser, around 4 to 8 mg per kg IV, followed by maintenance of 3 mg per kg per dose, but has to be given TID, where caffeine is only one dose. And the half-life is around 1.5 days, that is 30 hours. Therapeutic level is 7 to 12 mg per liter, and toxic level is when it is reaches more than 20 mg per liter. The adverse effects are similarly both in caffeine and theophylline. There is tachycardia, dysarthmia, feed intolerance, GER, jitteriness, and irritability. More of hyperglycemia is seen in theophylline. There can be even a signs of toxicity when it crosses that therapeutic value range. It can present as a tachycardia, cardiac failure, pulmonary edema, hypertonia, sweating, and metabolic things. And even theophylline, it has more of diuresis and GI bleed, even cause the seizures. Metabolism is excreted unchanged in the caffeine, and N-demethylation via CYP1A2, that is in the liver. And theophylline is also again secreted unchanged. Routine blood level monitoring is not required. In theophylline, it should be required because the toxicity is more in theophylline compared to the caffeine. Theophylline has been largely replaced by the caffeine citrate because of once a day usage, longer half-life, broader the therapeutic range, good safety profile, that is the lesser side effects, and elimination of close monitoring of blood levels also not there in the caffeine. Coming to the evidence of the caffeine, there is a one major study, that is CAP trial. It is one of the milestone which has helped to see the caffeine use not as a short term, even as a long term advantages also. This was done in 2006, where the population group were the birth weight of 500 to 1,250 grams and gestation age up to 30 weeks. And even the sample size was also 2006 babies were enrolled. Intervention was the caffeine, which was given for the first 10 days of life, a loading dose of 20 mg per kg, followed by maintenance of 5 mg per kg per day. And later on, it was increased to 10 mg per kg if there was persistent apnea. Control group was the placebo group. Primary outcome was composite of death and cerebral palsy, cognitive delay, deafness or blindness at corrected age of 18 to 21 months. Time period of 5 years from 1999 to 2004. It was done in 5 countries: Canada, USA, Australia, Europe, and Israel. Secondary outcomes were BPD, ultrasonographic signs of brain injury, NEC, and ROP. So here we can see that death in the caffeine group was 5.2 and placebo 5. It was almost nearly same, no much difference. But the difference, significant difference lies in the BPD, where it is around 36% reduction in caffeine compared to almost 46% in the placebo group. So odds ratio is 0.63. That is around 37% reduction of BPD was seen in the caffeine group. The other outcomes like supplemental oxygen, that can be through the just oxygen, nasal prongs oxygen or CPAP or through ventilation at 36 weeks of PMA, was around 36% in the caffeine compared to 47% in the placebo. As I discussed, the OR was 0.63, so there was 37% reduction by the supplemental oxygen by usage of caffeine. Even positive airway pressure also, there was discontinuation of 1 week earlier in the caffeine group. And even similarly, ventilation was also 1 week earlier. And postnatal steroids usage was also lesser, around 14% compared to placebo. The incidence of ROP did not differ significantly, but severe ROP was less in the caffeine group. The OR of 0.6, around 40% reduction was there. The median age of enrollment was 28 weeks. And in this study group, it was weaned off at 35 weeks of PMA. The caffeine received median days was 37 days. PDA was not one of the outcome which was measured in the CAP trial, but it was incidental finding. It was seen that medical closure and surgical closure, both the reduction was seen, which was statistically significant in caffeine group. Caffeine had a potentially adverse effect of diminishing the weight gain for the first 3 weeks after the start of the therapy. Here you can see the weight loss was more, and gradually after the 3 weeks, it did not make any significant difference. The CAP trial, when the follow-up study was done at 18 months. So in the composite outcome of death and neurodevelopmental disability, odds ratio was 0.77. That was around 20% reduction in the death and composite outcome, that is death and neurodevelopmental disability in caffeine group. Cerebral palsy around 40% reduction, cognitive delay also around 20% reduction, but it did not differ significantly in mortality, deafness, blindness, or in growth pattern like height, weight, and head shape. A follow-up at 5 years, they have seen basically on the cognitive impairment, cognitive and the motor functions. Motor impairment was defined when GM FCS level was 3 to 5, and cognitive impairment when IQ was less than 70. So in the caffeine, when the combined outcome was seen in the caffeine, it was reduced to 21%, OR of 0.8, so almost 20% reduction. But no, it was not statistically significant for the mortality or motor impairment, behavioral problems, or deafness and blindness. Cognitive impairment was actually lower at the 5 years compared to the 18 months, but similar in the both two groups. But there was improved motor function and visual perception compared to the cognitive impairment at the 5-year follow-up. At 11 years follow-up, the functional impairment was seen, that is composite of poor academic performance, motor impairment, behavioral problems, which showed no difference. But there was a significant difference in the fine motor coordination, visuomotor integration, visual perception, and visuospatial organization in the caffeine group compared to the placebo. Even you can see in the motor impairment also, there was significantly difference was there. That is around 19.7% in caffeine and 27.5% in the placebo. OR of around 0.6 where number needed to treat is 13. That is, if you treat 13 babies with the caffeine, one baby will be having benefit of from the motor impairment. There will be reduction in motor impairment. So other Cochrane studies like prophylactic methylxanthine for prevention of apnea in preterm infants. Here the Captrel was included along with two other small studies where they have measured the prophylactic methylxanthine versus the placebo or no treatment. The outcomes was the apnea, recurrent apneas, use of respiratory supports and death before hospital discharge. There was no meaningful difference between the caffeine and the placebo in the number of infants with the apnea and bradycardia. Uh, Even there was decrease in the risk of PDA ligation. Similarly, a Cochrane study on caffeine versus theophylline, also when around 5 trials was included, the primary outcome being the apnea and mean rates of apnea. Results showed that there was no difference in the treatment failure rate and was found between the caffeine and theophylline after 1 to 3 days treatment or 5 to 7 days of treatment. No difference was seen, but the adverse effects, that is tachycardia and the feed intolerance, were lower than the caffeine compared to the theophylline. There are certain studies were done to show to understand the dosage of the caffeine to come to the optimal dosage. So high dose versus low dose caffeine was also studied. There was a systematic review which included 6 RCTs where the high dose around 40 to 80 mg per kg loading dose and maintenance dose of 5 to 30 mg per kg per dose was given compared to the standard dose, that is 6 to 30 mg per kg, and loading dose to maintain dose of 2.5 to 10 mg per kg. The benefit seen was there was a reduction in extubation failure, reduction in BPD, decreased need for mechanical ventilation, reduction in episodes of apnea, decrease in duration of an ICU stay, and the side effects like tachycardia was seen in the high dose compared to the low dose. When compared with the early versus the late caffeine, the meta-analysis, which included 5 retrospective studies and 8 RCTs, early caffeine were given when within 2 hours to 3 days of life. Late caffeine was more than 3 days. In those studies, it was seen that early caffeine was preferred. The benefit, uh, the benefit was seen in reduction in BPD, decrease in PDA, and reduction in ROP and brain injury. Studies were done on duration of caffeine for the apnea. RCT and Indian study was done with included the preterms of 26 to 32 weeks of gestational age, which were divided into two groups. One group where the caffeine was stopped at 7 day of apnea-free period, and the second group were continued for the prefixed period till at least 34 weeks of PMA. So in these two, it was seen the outcome was to see for the recurrence of the apnea. So the caffeine could be stopped earlier around 33 weeks of PMA, and the cumulative duration of therapy was also lesser. It was around 19.5 days when stopped at the 7 day apnea free period. So in conclusion, the mandatory continuing caffeine therapy up to 34 weeks of PMA in select preterm groups does not seem to decrease the risk of recurrence of the apnea. So discontinuation of apnea, it can be done around 33 to 34 weeks of PMA. Generally acceptable to discontinue between 32 to 34 weeks if no apneic events recurring intervention over the previous 5 to 7 days. Actually, there is no trials which have addressed when to discontinue the xanthine treatment, that is caffeine. It depends on the case-to-case basis. Even in the CAP trial also, the weaning period was around 35 weeks. So if you consider extreme preterm babies who have underwent, who had severe RDS, who had undergone a STOMI NICU course and had BPD also are more risk for it, then you can give caffeine for a longer period, around 40 weeks. If it's a other moderate preterm or moderate or very preterm baby who did not have so much of stomachos, then you can stop around 33 to 34 weeks and see for a apnea free period of 5 to 7 days. If no apneas, then can be stopped. The therapeutic effects of the caffeine in infants, the established benefits were it was used as a treatment for apnea. It facilitates extubation with shorter duration of intubation and non-invasive respiratory support. Reduces the incidence of BPD, decreases the need for treatment of PDA, improves motor function and visual perception at 5 years of follow-up, and reduces the severity of ROP, as we seen in the capital. The possible or apparent benefits were the prevention of AOP related symptoms like intermittent hypoxia. There were several studies done on this also, where intermittent hypoxia was also reduced by using the caffeine. Prevention of postoperative apnea in the preterm infants undergoing general anesthesia. Prevention of apnea associated with viral bronchiolitis in young infants. Induction of anti-inflammatory cytokine profile. Incremental overall benefits if treatment initiated before 3 days of age. Adverse effects like short-term mild transient symptoms like tachycardia, irritability, diminished weight gain. Long-term were not seen. Unknown like potential benefits of extended duration of treatment after resolution of apparent apnea-related symptoms after 33 to 34 weeks PMA. Potential adverse sequence of extended duration can be seen if given for a longer period. The other pharmacological intervention like doxapram, which stimulates the peripheral chemoreceptors at low dose and central chemoreceptor at high doses. Adverse effects like irritability, hypertension, and decreased cerebral blood flow has limited its use. Treating gastroesophageal reflux, timing of reflux is in relation to the apneic events indicate that they are not commonly related, they are more of temporarily related. Apnea may precede rather than the flow reflex. So there is no clear evidence that the treatment of reflex will reduce the apnea in most preterm infants. Red blood cell transfusion, it remains the controversy whether to transfuse blood or not. So follow the transfusion guidelines. Even according to one of the study where the blood transfusion was done in very low birth weight babies, they monitored for the apneic events before and after the blood transfusion. So here you can see that is ABD, apnea bradycardia desaturation episodes before giving and after giving. There is so much significant reduction in apneic events after the blood transfusion. So blood transfusion was associated with decreased apnea and was also had and the babies who had higher hematocrit also had less frequent apneas. Discharge consideration in 2016 clinical report from the Committee on Fetus and Newborn. Clinical report and guidance for hospital discharge of preterm infants with apnea has to be established. A monitoring policy has to be there for the individual NICU. Trial of caffeine can be considered when an infant has been free of clinically significant apnea or bradycardia events of positive pressure for 5 to 7 days or at 33 to 34 weeks of PMA, whichever comes first. Brief isolated bradycardia that spontaneously resolved need not delay the discharge. Because of the considerable variation in practice, no concrete discharge planning guidelines have been recommended. The other ventilatory strategies for the treatment in apnea of prematurity are like CPAP, use of CPAP, HFNC, NIPPV, or mechanical ventilation. CPAP can be used with a set pressure PWP of 4 to 6, which reduces the number of mixed and obstructive apneic spells because it splints the upper airway with positive pressure and it decreases the risk of pharyngeal or laryngeal obstruction. CPAP also increases the functional residual capacity, and at a higher FRC, the time from cessation of breathing to hypoxia and bradycardia is also prolonged. Uh, Triple HFNC is also an alternative to the CPAP, which is largely used because it is more comfortable, it is less traumatic, and it is a patient-friendly interface is there, and especially in the more mature infants can be used. The limitation is the amount of PWP generated is unpredictable. Even the newer modes like NIPPV and nasal HFOV has also been used for the apnea of prematurity. NIPPV, there is augmentation of CPAP, which superimposes the inflations of set to a peak pressure delivered through the nasal prongs or mask. There is an intermittent inflation of the pharynx, which activate the respiratory drive by Head's paradoxical reflex, which causes the lung inflation, provoking an augmented inspiratory reflex, resulting in resumption of the breathing, that it terminates the apnea. Nasal HFO also can be used to prevent the apneic episodes through the regular oscillation, which helps in reducing the PCO2 levels. Mechanical ventilation can be used if there is a severe refractory episodes, even if the baby is on the respiratory support or the blood gas is showing the respiratory acidosis due to the apnea. But here the settings will be minimal ventilator settings will be required if there is only apnea of prematurity and should be used to allow for the spontaneous ventilator efforts and to minimize the risk for even barotrauma. Cochrane review on NIPP versus the nasal CPAP. The two trials were taken into consideration in 2008, where it was seen that greater reduction in the frequency of apnea was seen in the NIPPV when compared to the nasal CPAP, around mean difference of 1.19. But there was no data related to the gastrointestinal complications. So NIPPV appears to, even you can see there was a significant change in the decrease in the incidence of the apnea, giving mean difference of around 1.1. NIPPV appears to reduce the frequency of apnea more effectively than the CPAP. Additional safety and efficacy data required before recommending the AP as standard therapy for apnea. Limitation only short-term effects were compared in both the studies. If you see the consequences of the apnea of prematurity, it can lead to ROP. There can be BPD, respiratory instability like sleep disorder breathing, altered growth and cardiovascular regulation, cerebral injuries and neurodevelopmental disabilities, disruption of zinc hemostasis can also be seen if there is persistent apnea of prematurity. So, apnea of prematurity and SIDS, there is no direct evidence of a causal relationship between these two. Home monitoring to decrease the incidence of SIDS is not recommended as it does not reduces the risk of SIDS. Apnea is generally seen to resolve around the 44 weeks of PMA, and in extreme premature infants, SIDS typically occurs at approximately 47 weeks. So, AOP is not an independent risk factor for the SIDS. There are many upcoming therapies in the apnea of prematurity, like olfactory stimulation, mechanosensory stimulation, sound stimulation in the form of music, that is music therapy. These all have a potential influence on the cranial nerves, causing stimulation and maturation of them. To establish a therapy in this, we need a large prospective RCTs to evaluate these therapies. So, in summary, this apnea of premature reflects the immaturity of the respiratory control. The generally resolves by 36 to 37 weeks of PMA in infants born at equal to or more than 28 weeks of gestation. If they are below 28 weeks of gestation, it can persist beyond the term. And that is the time when you can continue the caffeine up to 40 weeks of PMA. Individual NICU has to encourage for to develop a policy regarding the cardiorespiratory monitoring for the at-risk babies and caffeine is considered safe and effective. It can be started in babies less than 32 weeks and less than 1.25 kgs prophylactically also. Treatment of presumed or proven GER solely for the reduction in the apnea events is not supported by currently available evidence. A clinically significant apnea event free period before discharge of around 5 to 7 days is commonly used. Along with a longer period can be required if the baby is less than 26 weeks of gestational age. Home monitoring is usually not routinely recommended. Thank you. Any questions or any doubts?